keep an eye on the questions in the chat as well, please, and let me know if I don't see anyone. Right. Right. Sam, can you give me a wave if you can see the slides? Is that all right? Yeah, brilliant. Okay. So we are going to talk today about the local extension to the Pharmacy First service, so the local minor ailments extension that Sian has helped us get commissioned. Well, Sian's pretty much done the whole thing, so thank you very much, Sian. We are going to talk a little bit about the background and how she's managed to get this service up and running. Brief service overview, how it integrates with Pharmacy First, and what we need to do to get the service up and running. We're going to very quickly go through the 4 conditions that are covered by the new PGDs for this, and just clarify any expectations and next steps forward for us. And there'll be time for questions and answers at the end. But as I said before, if you want to ask any questions throughout, please do just stick your hand up or write in chat, and we'll cover the questions as we go along. Okay, so why has the service been commissioned? So hopefully you're all aware of the aims of the Pharmacy First service, which is to relieve pressure on general practice, urgent care and emergency departments, and enable pharmacists to deliver services more at the top of their clinical license, to deliver more clinical consultations. This service specifically has been commissioned to align us with Bristol, North Somerset and South Gloucestershire. So going forward, Gloucestershire has clustered as an ICB with Bristol, North Somerset and South Gloucestershire. They are very much in the process of reorganising, restructuring. People are moving around at the moment, as we have said in previous meetings. So over the next 6 to 12 months, these 2 organisations, Gloucestershire and BNSSG, will move towards a more integrated way of working. They're clustering together, and so we were changing the way that we're working slightly to align more with services that are going on in Bristol, North Somerset and South Gloss. So if you do have other contracts in BNSSG, or you have worked as a locum or a pharmacist in BNSSG, you probably will be familiar with this service. So fantastic. And if you haven't, please do listen and feel free to ask questions. Going forward as well, hopefully you've all had a chance to look at the community pharmacy contractual framework for the next 12 months. We are hoping that from this autumn, there will be a national IP offer, which will very much support the minor ailments agenda. We're not sure exactly what prescribing only pathways are going to be commissioned. They still haven't agreed them with Community Pharmacy England, but we're thinking they're going to be very similar to these pathways that we're going to talk about tonight, as well as potentially respiratory tract infections, possibly, and the ability to make, for the independent prescribers, to make minor adjustments and changes to prescriptions already written. So, for example, Ramipur tablets are out of stock, can give capsules, well, the other way around. Ramipur capsules are out of stock, we can change a prescription to give tablets. Anything else specifically you wanted to mention here, Sian, before I move on? Assuming not, right? Fantastic. Okay, so as we've said, this is a locally commissioned service that actually builds on the Pharmacy First consultation model. It's only for trained pharmacists at this point of time, and it's PGD service. So although technicians are allowed to use PGDs, this service, because it aligns with the Pharmacy First consultation model, is only for pharmacists. And it is 4 PGDs, which increase the range of conditions that can be assessed and treated via a funded service in community pharmacy. So the 4 conditions are nystatin for oral thrush, chloramphenicol for bacterial conjunctivitis, otomides for otitis externa, and hydrocortisone for minor skin conditions. Now, as part of the Pharmacy First service, if you get a minor ailments referral for one of these conditions, you can assess them already under the Pharmacy First service. But this just allows us to, a PGD allows us to then also provide treatment if appropriate. So it's a sort of a next step on from minor ailments consultations. How does it align to the existing Pharmacy First pathway? So the service pathway for this one is almost exactly identical to the Pharmacy First pathway. So patients can walk into the pharmacy, they can be referred from general practice from NHS 111 or urgent treatment centres, or they can access one of these 4 new PGDs after you've done an initial Pharmacy First minor illness consultation. So if you get a referral from a GP, an electronic referral for oral thrush, you would assess under the National Pharmacy First service, and then if appropriate, you can divert into this service to supply medication under PGD. Everything else is exactly the same as the National Pharmacy First service. So you will be expected to do a consultation in a private consultation room. You will be expected to undertake a complete clinical assessment and make good contemporaneous notes, record your consultation on the point of care system, apply PGD criteria for if you're wanting to supply medication under PGD. And the outcomes are pretty much the same as the national service. So you could, at the end of the service, just give advice. You could give advice and recommend an OTC treatment or sell an OTC treatment. You can refer and escalate along the same pathways. The only difference is that you now have these 4 PGDs locally, so you can supply treatment on the NHS. And the last step of the service, not forgetting to make sure that you record all advice and safety netting given as part of your clinical consultation. So it integrates almost exactly with Pharmacy First. You will use the same structured consultation style. You'll record on farm outcomes. So because it's a local service, Sam has built the modules for recording this onto farm outcomes, but they should be all structured almost exactly the same as the Pharmacy First consultation modules. National prescription charging rules apply. So for any adults accessing the service, you would need to check if they're exempt. And if not exempt, make sure you charge them for medication. It complements the national service by expanding the local treatment options and covers these additional range of patients, and it supports self-care and OTC sales, antimicrobial guardianship, and managed supply of medications. Okay. The biggest difference probably with this is that there's actually technically no gateway criteria. So within the National Pharmacy First service, for the clinical pathways, you will have a clinical pathway document with a nice flow chart on it and a couple of gateway points. And at the end of your consultation, you then assess against the PGD. And if you've hit a gateway point, whether you then move to PGD or not, you would claim. Within this service, the gateway criteria are technically the inclusion criteria for the PGD. There's a slight difference in the payment structure, which we will cover later on. The 4 pathways here, 2 of them include infant care, which is not within the national, obviously the Pharmacy First service. So we're looking at patients under a year of age. So you do need to make sure that you're competent to deal with infant patients. And obviously the PGDs are locally commissioned rather than a nationally commissioned. So if you move out of county with this, you can't deliver the Gloucestershire service. To get ready for operational delivery, there's no real mandatory training before you go live. What you must do, though, is you must read, understand the PGDs, print them and sign them, and you must be clinically competent in the conditions that have been added. Now, you should be clinically competent in these conditions anyway, because they're only minor ailments conditions, but you just need to make sure that you have looked at your own knowledge and learning, identified if there's any gaps there, read the most up-to-date nice guidance and prescribing guidance there as well. And again, with the same as any other PGDs, you need to be competent in using PGDs, understand that these are legal documents, they are very black and white. So if the patient doesn't meet one of the criteria, you can't just say, oh, we'll fudge it, we'll just get you through and I'll give you the medication anyway. They are black and white. If they don't meet the criteria, you cannot supply. And you do need to make sure that you're maintaining your competence and keeping up to date with any local and national changes that are going on. So before we look at the 4 conditions, Sian, is there anything you want to add at this point, or shall I keep going?
You probably want a break. Is that what you mean? Have a sip of water, and then just to echo that this service is all about using our community pharmacy colleagues and the successes that your teams have illustrated to all and sundry, both locally, regionally and nationally, with delivery of the Pharmacy First services. So it's credit to you guys in terms of that delivery that sort of I was able to seek the funding from our executive board and be able to support you guys in supporting more patients and avoiding that bounce back to general practice, which frustrates our GP colleagues when you bounce back because of the product license, chloramphenicol in the under twos, or that sort of, so, you know, or for hydrocortisone for use of the face. So it's all is making sense, so that you can use all of your skills and support more patients. I think sort of, again, it wasn't just me, it was a very much a team effort working with Sam and Becky at Gloucestershire LPC and our BNSSG colleagues and the Community Pharmacy Avon and Wiltshire, and Kim has ably supported me as well. So thanks to you guys and thanks to everybody aforementioned. Right, are you hydrated?
Yeah, yes, it's not water, it's gin and tonic. Sorry, we'll blank that out of the recording. Okay, so we're going to look quickly at the 4 new conditions. So the first one is otitis externa, or inflammatory conditions of the external ear canal where you suspect a secondary infection. Obviously, we've got otitis media on the Pharmacy First service at the moment. Otitis media is inflammatory conditions of the inner ear. So this is the outer ear, anything up to the eardrum. The inclusion criteria for this service are adults and children over 2 years of age, where you've got symptoms that are moderate or severe and not managed by conservative treatment. I'm not going to go through in great detail the exclusion criteria, just to highlight the risk around ototoxicity and the MHRA alert that's been pushed quite a lot recently, and sort of the aminoglycoside risk covers not just topical treatments here, but just sort of bear in mind that for any oral products or anything that, I know we don't supply many of these very often orally, but you know, so there is an increased risk of deafness in patients with a family history of deafness because they have this mitochondrial mutation. So if you're unfamiliar with the alert that came out a couple of years ago now, I think it was 18 months or so ago, please make sure that you review it. I've put the link in here, but it's clear on the website. So this PGD allows you to assess patients and then supply Otomize ear spray, 1 dose 3 times a day for 7 days up to a maximum of 14 days. The PGD does cover the advice that you need to provide to the patient, as well as safety netting advice that needs to be provided. Quick overview of the condition, as we said before. So at least one typical symptom of itch, ear pain of the tragus opinia, possible referred jaw pain, discharge, hearing loss, common due to ear canal occlusion. And so at least one of those symptoms and at least 2 other symptoms, including tenderness, redness, erythema of the tympanic membrane, or tender regional lymphadenitis. I can never say that. Just so remember your lymph node check. When this PGD was launched in Bristol, feedback from the LPC down there is that they did have a lot of initial referrals from GPs and initial claims of patients with earwax. So we will not be accepting claims where you have assessed a patient and it's earwax. This is a service for otitis externa, and we would expect to see, you know, a good clinical assessment of symptoms. If it's earwax, they could be referred to a private or an NHS service for removal of earwax. But, you know, if it is otitis externa and it can't be managed by conservative treatment, so, you know, keeping the ears dry, ear calm ear spray, acetic acid ear spray, those are your sort of first line, then you can now supply Otomize for otitis externa. I put in a quick link here as well. This is a fantastic website that I found quite recently. This entuk.org is the ear, nose and throat surgeons website, and they have some fantastic patient leaflets on here about otitis externa, otitis media, earwax, things like that. And they've got them all linked with QR codes. So you can literally cut off, you know, you could literally print this off, stick it on your wall and get a patient to scan a QR code if you're doing a consultation with them. Sam, you had a question.
Yeah, there's a question in the chat. Otomize, as it's now generic, does the PGD cover this?
Does it? I can't remember. It should do. Yes. Sean's nodding. We'll make sure it's written, it's worded appropriately to cover the generic as well. Okay, any questions about the Otomize? No, lovely. You can email in any questions or save them for the end. That's fine. Next one is mild inflammatory skin disorders. So this is the hydrocortisone PGD. Hydrocortisone you can buy over the counter. If you're a pharmacist with a lot of experience, you may well be happy selling hydrocortisone outside of its specific product license and taking a calculated risk, although this is not something that we would say you would or wouldn't have to do. But the PGD now allows you to make that supply for where use is outside of the product license. So adults and children aged 10 years or over for use on the face. So obviously that's unlicensed with the OTC product at the moment. Children 1 to 9 years, so obviously the OTC license is from 10, so we'll be able to supply from 10 with acute dermatitis, mild eczema or insect bite reactions. One of the exclusion criteria for this is if there is a licensed OTC product available. So if an adult presents with mild acute dermatitis behind the ear, that's actually allowed within the product license, so it wouldn't be allowed on the PGD. You know, or if an adult presents with a rash on the arm, that sort of thing. So if it's already within the OTC license, you would need to supply OTC. This is for situations where the OTC license doesn't apply. And the conditions are acute dermatitis, atopic eczema and insect bites. I've put in the picture of insect bites because in this picture here, then these aren't actually infected. And I do know that we sometimes have a bit of difficulty identifying infected and non-infected bites. So there is a fantastic, nice guidance around infected bites here with a lot of good symptom control in it. And do make sure that when you're speaking to patients about insect bites, most bites don't require antibiotics. It's only a very small percentage that will, you know, require antibiotic within the national pharmacy first pathway. So please make sure you're doing robust clinical history taking. I have put in the pathway for infected insect bites here to show that, you know, even though the gateway point, hang on, I'm moving you out the way there. The gateway point for the infected insect bites national service is quite low down. There's actually 3 points within this pathway where you could divert patients into the local service if it's appropriate. So has it been within 48 hours? Here's the self-care window here, self-care oral antihistamine and topical steroids. So that's where you could divert into the PGD. Is itch the predominant symptom? Again, here's the self-care bubble. So that is where you could divert into the local PGD if necessary. And within the gateway, past the gateway criteria, but within the I haven't supplied antibiotics bit, again, there's a self-care bubble there. So there's a couple of points within the national protocol, the national pathway, where you can divert into this local pathway. The third service is bacterial conjunctivitis. So this is only for children under the age of 2 and only for infective bacterial conjunctivitis that's severe or likely to become severe. So now, obviously, we all know that conjunctivitis, most cases of conjunctivitis are suitable for self-care. So boiled and cooled water, cleaning the eyes regularly, monitoring, what have you. This one is for obviously severe and likely to become severe conditions for children. I'm not going to go through this. I'm not going to go through this in great detail. There's a nice little table here for how you could potentially distinguish between bacterial, viral and allergic conjunctivitis, so sort of your differential symptoms. What I will mention about eye care is that if you need urgent ophthalmological assessment or escalation, so if within your history taking, you're checking for flashes and floaters, blurred vision, spots, pain in the eyeball, that sort of thing, sensitivity to light. 2 pathways here. Obviously, any signs of sepsis or systemic infection, A&E. severe eye pain with other symptoms, A&E. Any other eye symptoms that are not suitable for treatment within pharmacy, you can actually refer to the CUES service. And hopefully you will know about the CUES service, which is the Community Urgent Eye Care Service. And this is a fantastic service. My family have used it twice, once for a blood clot behind the eye, which was identified through the CUES service and escalated to hospital, and second for acute closed angle glaucoma, which was obviously increased pressure in the eye, which was picked up through the CUES service and again escalated same day to the hospital for urgent eye surgery. So primary eye care website. If you go onto here and type in a postcode, it will bring you up a list of all the local opticians who participate in the CUES service. Pick up the phone to one of them if you've got a patient stood in front of you and ask, have you got a CUES appointment? They are contracted to keep a couple of slots a day open, which most of the time they do. Some of them are not so good at doing this if they're very busy, so sometimes you have to phone a couple of local opticians to find an appointment, but generally you'll get a patient in the same day or early the next day for an assessment with an optician or an ophthalmologist in a local opticians. The opticians can then refer and escalate more serious conditions through to urgent eye care in the hospital. I would not recommend you phone urgent eye care in the hospital because the phone line takes about an hour to be answered. A receptionist answers it. In order to get any information on the urgent eye care line, they have to find a nurse. The nurse then has to find an ophthalmologist quite often. So it's often quicker to go through the CUES service if you need urgent eye interventions in the community. And we're on the last one. Yes, we're on the last one. The last of the four is oral thrush. So this only covers nystatin and it's only infants aged between 4 weeks and 4 months. So it's a very small cohort of patients, but actually it's the cohort of patients that you can't, give metconazole to, and that are more likely to get oral thrush initially, obviously due to breastfeeding issues, latch, incorrect cleaning of bottle nipples, that sort of thing as well. One point on this slide, please, the diagnosis of oral thrush quite often, the main diagnosis depends on your history taking, clinical appearance, but also scrapability of any lesions off the tongue. Things that can't be wiped off tend to be more serious than white gunk that can be wiped off, but please don't put your fingers in a patient's mouth or a child's mouth. Give a parent a sterile gauze swab and ask them if they can just sort of gently swab the child's tongue and observe before and after. So generally you'll see a white crust on the tongue. Afterwards it might be slightly reddened, a bit inflamed. If it's obviously bleeding and there's further lesions underneath it, you would escalate. But yeah, please don't put your fingers in a patient's mouth to do this yourself. Get the parent to do it. Okay. Anything I've missed there, Sian, that you want to pick up on? Yeah, obviously that was a very whistle-stop tour. You should already be familiar with the clinical conditions, and when the PGDs are launched, please do check the PGDs, read the PGDs, and make sure you're familiar with the inclusion, the exclusion criteria, what advice you should be giving to patients, safety netting, etc. So to summarise the clinical pathway, it's exactly the same as your pharmacy first consultation. So you will be assessing a patient and identifying the condition, undertaking a clinical consultation, documenting that contemporaneously. So do it at the same time, do it well. If you're a bit unsure about clinical record keeping, please go onto the LPC website and review our webinar that we ran earlier on in the year with Tom on clinical record keeping and note taking. Fantastic webinar from him. So just go back onto the LPC website and have a look at that. When you're assessing against the PGD, do check the inclusion and exclusion criteria, and the outcome of the consultations are the same as they are within the pharmacy first service. So advice and OTC self-care should always be your first point of call wherever it's appropriate. Sell medication wherever you can. if it's appropriate, before supplying under the PGD. So making sure you've good antimicrobial guardianship. If it's only mild to moderate conjunctivitis, can they do boiled and cooled water, and you safety net them to return if symptoms become more severe. And again, make sure you record this, and it sends a notification to the GP via the clinical system. Payments. This has confused us a little bit. So payment can be claimed if the PGD criteria have been met. It's £17, the same as the national service for the clinical condition documented and claimed through farm outcomes. You are also able to claim if you have completed a consultation under the National Pharmacy First Service and are then diverted into the local service. So, for example, a referral from your GP for an electronic referral from a GP for a minor ailment condition for thrush in a 3-month-old, you would claim that as a Pharmacy First minor ailments consultation using the national service, and you can then divert into the local service and claim an additional £5.90 if you're supplying medication under the local service. Medication is reimbursed at the drug tariff price. Take away the cost of any prescription charge. So we're not going to be collecting prescription charges off you, but you will obviously deduct the prescription charge out of the invoice. This does not contribute towards the National Pharmacy First thresholds or caps. So, the 30 a month to get your payment, if 10 of them are oral thrush in a 3-month-old, those won't count towards your national thresholds. So you need to do 30 on the national service to get your threshold payment. And claims must be submitted on farm outcomes by the 5th of the month for local payment. So this doesn't go via MYS or NHS BSA. Payment for this is being organised by the LPC. So the ICB have already transferred funds to a separate account that the LPC are administering on behalf of the ICB to pay for this. So as long as you've submitted your claim by the 5th of the month, Will, who's our treasurer, will be logging on and paying all those invoices directly to you. So in the setup process of this, we will be contacting pharmacies that have signed up to this to make sure we've got correct BACS details for you so that we can make those payments to whatever account you say you want them to. This was just an example, which I think I've already talked through about, where you would claim which service from. So if a GP refers a 4-month-old patient electronically for oral thrush, you can claim a minor ailments under the national service and a local service one. If the GP refers them verbally or the patient walks in with the 4-month-old with oral thrush, you would use the whole service on the local template, and you can claim £17 on the local service for that. If you're claiming national and local, your GP will get 2 notifications. So that is something that when we're setting up the service, we do need to make sure that GPs are aware of, because we won't be able to combine them all into one notification. So they'll get a notification about the national using whatever point of care system you use. Then they'll get a separate email to say, and now we've done it on the local service as well. Whereas if you're not claiming anything on the national service, they just get 1 notification. Sian.
Yeah, just to clarify, just in case anybody's confused, if it's a referral from general practice under minor illness, you claim the £17 from national, and then we give you a top up because you've got to go back into some paperwork of £5.90 in order to issue the item under a PGD. You do not claim £17 from national for the consultation and £17 from the local service. It is either or. So the £17 is one payment, either via national or via local. So yeah, please don't think you can claim both.
Also, to clarify as well, as long as the patient meets the PGD criteria, if you get through to the end of your consultation and then you and the patient come to a joint agreement, shared decision making that actually I'm not going to get chloramphenicol, I'm going to use boiled and cooled water for self-care, you can still make the claim as long as you've met the criteria. You don't have to supply medication in order to make the claim for delivering the service, because it's based around I'm doing this clinical assessment, this consultation, and we are asking pharmacists to use their professional judgment here. If you've spent 20 minutes doing a consultation, but someone's failed at the last hurdle to meet a, to meet a criteria, we'll accept, we'll give you £17 for that. So you've made a big record, you've stopped this patient from going to the GP or out of hours, then common sense will apply. Sam, was there another question?
No, it was just, I thought it was worth saying at that point that it is very clear on each of the templates. You have to tick a box to say whether you've got a referral from a GP, whether the patient's walked in. So it's quite simple, although it sounds quite confusing when it comes to the template. It's quite easy to work out, how much you're going to be claiming for, and it will automatically do that for you on farm outcomes. So you won't be able to kind of double claim and make an error. It will be very clear when you look at the templates. Hopefully.
Thank you, Sam. And because this is a local service, if anything isn't clear, we can get Sam to change it so it is, which is great. This is sort of a very nice table this is actually within the service specification that will be going out to contractors when they sign up for the service, that just sort of explains sort of where the funding is coming from and where, and it's this middle one that we think is going to be a bit confusing, but it's if you have claimed a £17 for your consultation through through the national service, you can only claim that top up through the local service. Okay, so looking at the role of your pharmacist team, so obviously this is a pharmacist-led consultation and assessment, but obviously you can't do it on your own. Your pharmacy team is vital to making this run smoothly. So what can they be doing? Exactly the same as within the Pharmacy First service. So identifying and engaging patients. Make sure your teams are aware of the 4 new clinical conditions that are potentially available to claim money on. Make sure that your team understands how the patient moves through the service and the flow and can explain it to the patient. Look, you'll be having a consultation with the pharmacist in the consultation room. They will assess you, etc. Your team can be doing documentation. So if you're not the most if you're not the most IT savvy person, if you've got the capacity to have an extra, an extra member of staff in there typing notes for you, and the patient agrees to this, you could have someone in there typing up your notes as you go along. Your team is quite good at escalating. So if you have to phone the general practice to get an appointment for the patient, your team can be the one that look up the number on the service finder website to find the healthcare professional's number. They can be making calls to NHS 111 via the healthcare professional line and doing the escalation. And they're vital to ensure the smooth running of the pharmacy while the pharmacist is in consultation. I have put a few bits of feedback on here around sort of words and phrases that people are finding very useful to engage patients in the service. So we are getting a bit of feedback that, how do I convert people who are walking in and get them in the consultation room? And we've been asking, people who are very good at this, what are they saying to patients? So we may be able to treat you here for that with our pharmacy service. Our pharmacists can assess that and, if appropriate, provide treatment today. You don't need to see a GP. We can help you here, that sort of thing. And then explaining what will happen. So an informed patient is more likely to consent if you explain, the pharmacist will take you into the consultation room. You can bring someone with you if you want. So you don't have to be on your own in there. They will ask you some questions. They might do your temperature and blood pressure. And if it's not suitable, they will make sure that you're escalated to somewhere that is suitable. So whether that is, and that may include phoning your GP and getting you seen at your doctor's surgery. So that works quite well. Handling the I think I need a GP. I won't go through this. I'll we'll put the slides up anyway, and you can look at this in your own time. But this is sort of someone we talked to a couple of counter assistants who are very good at this, and and said, you know, what happens when the patient says, oh, I need a GP. And this was a pharmacy that was attached to a doctor's surgery, so it was quite easy for the patient then to walk next door to the doctor's surgery to try and get an appointment. But they were very good at saying, well, actually, hang on, you know, you might not need one, let the pharmacist assess it first. We see this sort of thing all the time. We can often treat you without you needing to go and queue up and try and get an appointment and come back, etc. And the explaining and the reassuring are key points for this. So if you've got people on the counter who can reassure the patient that actually, you know, if it's not something we can treat, we will get you seen appropriately, then that does wonders for reassuring the patient as well. So what is going to happen next? So tomorrow, I think, are we looking at tomorrow? Fantastic. Yep, Sean's nodding. Tomorrow, the service specification is going to be sent out to pharmacy contractors, so owners and area managers, etc., things like that. The service specification needs to be read and signed and returned to the ICB. Returned to Kim, I believe, at the ICB, but all that information will be on the email that's going out. When the service specification has been returned to the ICB, Kim is going to let Sam know, and Sam will enable the pharmacies that have signed up on farm outcomes, and all these 4 templates will unlock on farm outcomes. Once the farm outcomes templates have unlocked, pharmacists, you will need to read and sign the PGD, and we will send out the links to the PGD because they will be on an ICB website. So the PGDs will all be available through farm outcomes, but they'll also be available on a website, which we will send out so you can look at those and read them beforehand. Read and sign the PGD. Make sure you've identified and completed any training, brief your team. And then in the same way for a lot of other services, you just need to do an enrolment on farm outcomes. We suggest you do this before you start the service, so you don't have to do it when you have your first patient standing in front of you, because there are a couple of declarations that you need to do on there. Basically things like, I've got my DBS check, I've got safeguarding training, there's a SOP for minor ailments, etc. You won't need a separate SOP for this because it so closely aligns to the Pharmacy First service that your Pharmacy First SOP will be absolutely fine. And yeah, make sure you've got some nice statin and chloramphenicol and generic atomizer in stock. Okay. And a couple of reminders before we finish. So when you start consultations, please try and maximise your consultations from referrals and walk-ins. So converting those patients that are coming in to consultation, even if you don't supply the medication at the end, if they meet the criteria, you can get that, you can make that claim. We really need to make sure we're maximising consultations. We're improving our consultation records. They need to be contemporaneous and robust, because come the autumn, when we start to have a nationally commissioned IP service, we need to make sure that we can do this so that we have more referrals, there's more confidence in the system, and that we get, I mean, Gloucestershire has a fantastically high number of independent prescribers compared with other areas of the country. So I'm confident that when we have an IP service, we're going to run with this. But this is all building towards a really good minor ailments, robust minor ailments, first port of call for community pharmacy. And we have to deliver this, otherwise we won't get given other services. Follow the PGD strictly, good antimicrobial guardianship, and give confidence to others in the system. We still have feedback that people are supplying antibiotics that aren't on the PGD, or for patients where it's not appropriate, where they've already had multiple courses of antibiotics. You have to follow the PGD strictly, and you have to consider your antimicrobial guardianship and document it, within your clinical notes. Discussed use of antibiotics with patient, decided to try self-care to start with. That's evidence that we are doing this and doing it robustly. Escalate using the correct local escalation pathways. So if you don't know how to use the Service Finder website to find the GP's backdoor phone number, please contact Sam and she'll send you information on how to do that. We've got that, haven't we, Sam? Yes, fantastic. Please use the healthcare professionals line on NHS 111. Don't tell patients to phone 111. escalate them. You as a healthcare professional have already triaged this patient. They don't need to then go through a computer algorithm and a second triage. You've done it. You know what they need. Phone the healthcare professionals line and get them to the right person. And make sure you're recording advice and safety netting as part of your consultation record. If you don't record it, it didn't happen. There's no point in sending someone away and saying, you know, come back to me in 2 days if things aren't better, and then they're in hospital in 2 days. If it's not on the you know, if you haven't recorded that you've said this, you know, if it gets worse, come back. If it gets worse, see your doctor. If it's not on that record, you didn't say it. So please make sure you do it. And claim correctly. If you have any queries about claiming, please drop us an email and we'll be able to help you with that. If you've done it wrong or think you've done it wrong, let us know. This is all locally administered, so we can sort things out locally, fix things if they've gone wrong. If you've missed one, if you've forgotten a claim, you know, let us know and we can sort it out. Okay, and I'm going to stop recording and see if there are any other questions. Stop sharing. And stop recording.